If this is like,
No, yeah, right. This is like.
Yeah, you want to.
Yeah, exactly.
Right. Well, is it?
Yeah.
Well, do you want to check your phone? Okay, person link in our. Is the link in cafe? So.
Nah, I haven't listened yet. No, it's not.
So yeah, it's live stream as well. That's what Will was doing. We're just trying to see if we can get into the. I'm not sure how many of you guys watched the live stream.
I thought a lot of people watched it.
Really?
I rewatched it.
Oh.
Yeah, I rewatched it.
I mean, this one's fairly buzzwordy, so it's not the best way to learn, but it's the best way to pass the exam. So yeah. I'll just wait for Will to let me know if it's working.
No, just go with it. If it doesn't work, we'll just.
Sure.
Post this last
No, but as in, can we get the link to? Oh, you're just gonna upload the YouTube video after.
No, I'm gonna upload it now. You can
Oh,
start.
okay, sure. Okay, cool. I will start. Okay, so lower GIT is a pretty high yield topic. In my opinion, it's probably just as important as upper and hepato, if not more important. And we had like a shitload of questions on it each year, particularly in the surgery section. So with a lot of the perianal problems. So I think it's good to know it in a decent amount of detail. We also had an OSCE station on the lower GIT issue last year. So it was examiner. Code grade.
Attention met, BAS ward, bed 20, Gen Surge 2 unit. Attention met, BAS ward, bed 20, Gen Surge 2 unit.
Yeah, so last year for one of the OSCE stations, we had an abdo exam, and after that we had to interpret a an abdo x-ray, and the diagnosis was bowel obstruction. So I think it's good to know such conditions in a decent amount of detail. For today, we're going to cover quite a lot, but I'm going to try and cover it within an hour so that you guys can have some break. So this is everything that I'm hoping to cover, so it's quite a lot of stuff. And we'll also do some EMQs at the end. Okay, appendicitis. What is it? Not a trick question. Yeah, pretty much. So acute inflammation of the vermiform appendix. Vermiform is apparently a word for worm-like, and the appendix was considered worm-like when they first saw it. So yep. Epi, it's the most common surgical emergency by far, with about 6% of all people getting it, and the highest incidence is in adolescents, so between 10 to 20 years old. It's good to know classifications as well for appendicitis. So the way I learned it was this pathological classification in which there are 3 types, and there's a timeline, which is either acute or chronic. So pathologically, there's mucosal, phlegmonous, and necrotic. And necrotic, as its name suggests, is the worst one. So if you suspect a necrotic one, you have to treat it, otherwise it's going to lead to perforation. Timeline, you have acute or chronic. Chronic appendicitis is most of the times diagnosed as an acute episode happening in a chronic case. So you don't really have chronic appendicitis because it's undiagnosed, but someone can present with like an acute flare-up. Etiology. So do you guys have a couple of guesses as to what do you think the cause of such a disease is?
Idiopathic.
Not really. So funnily enough, there are actually documented causes for this. So if it's in the bowel, what do you think could possibly cause? Yeah, exactly. So fecal matter is one of the big ones. There's also lymphoid hyperplasia. So if your immune cells there, and I think the last one is fecal lid, lymphoid hyperplasia, and obstruction. So it's pretty much anything that obstructs the lumen of the appendix, which in turn is fecal lid, normal stools, and lymphoid hyperplasia. Yeah. So fecal lid is like kind of abnormal stool in a way. It's also good to sort of classify this by age. So children and young adults, primarily, they're not going to have a lot of problems with their poo. So it's mainly hyperplasia of the lymphoid things. So things like tonsillitis and all that might possibly cause that as well. In adults, it's strictures or fecal lids, and as well as cancers, which can sort of obstruct the lumen of the appendix. And rarer causes include parasites and viruses and foreign bodies, but you don't really need to know this. I've got the pathophys here, and it's quite detailed. You don't need to know this in the entirety of its detail, but do know that the bacteria involved in causing the actual sort of perforation, if that does occur, are E. coli and Bacteroides fragilis. This could definitely be asked, so just know that. Everything else about the pathophys is a lot of detail. Essentially, lumen gets filled, and then the increase in pressure causes all the symptoms we get. This is more of a fourth year slide as well as a second year slide, but I think it's good to have some idea of the anatomy of the appendix. So it's a vestigial organ, which means we don't really use it for anything, connected to the cecum with large aggregations of lymphoid tissue. And the point of attachment of the appendix is very, very variable. So if you look at the position of the appendix, it can pretty much be anywhere along here. But the main position is the retrocecal position. So it's that one over there, the one with the 64%. So that's the main position you can see in appendix. But an appendix can be like anywhere. So it's just important to know that. Arterial supply, there's 3 arteries supplying the appendix, but all of them originate from one artery. Do you guys know what the main artery is? Come on, guys. That's right, cool. So the main artery supplying the appendix, just remember this for like buzzword sakes, is the SMA. So 3 arteries supplying the appendix, and all of them come from the SMA. Sorry, just give me a second. Yeah, so yeah. Any questions about any of that? You, in all honesty, in a third year level, you won't really be asked about this, but if they do ask you some questions where they're like, someone ligates an SMA and like what structures are at risk, if the appendix is one of them, just know that it's the answer. Okay, complications of appendicitis. We've been through a couple. Do you guys want to like read some? Sorry. Complications of appendicitis. So if someone has appendicitis and you don't really do the surgery, what could go wrong? Yeah. What's the big one? The other P. Perforation, exactly. So those are the big ones you got to be aware of. So perforation is mainly common in young children. Sometimes you can get a sort of mass in that region that's just like a sort of chronic case of appendicitis, and you can also get abscesses as well. Differentials for appendicitis depend on age. So if it's a young kid, the most common one you need to know at a third year level is something called mesenteric adenitis, and that often comes after a cold. So like mesenteric adenitis and appendicitis present very, very similarly. So there's also Meckel's diverticulum and menstrual symptoms in perimenarchal girls. So the first episode of menarche. Adults, there's a whole heap of things. Pretty much anything in that region can that can sort of manifest. So ectopic pregnancies, IBDs, PID. Do you guys know what PID is? So that's pelvic inflammatory disease, which is pretty much bacteria going from the vagina into the female reproductive system. Cystitis, perforated gastric ulcers, and renal colics. In older adults, the main thing you've got to be aware of is tumors, because a tumor can sort of obstruct the lumen of the appendix and can manifest as those symptoms. The classic textbook pattern of presentation that we all learn about is pain is initially periumbilical, but then sort of localizes to McBurney's point, and when you palpate between the acis and the umbilicus, you start to feel the tenderness. That's very rarely seen in real life. You get a lot of other symptoms as well. So you get malaise, anorexia. In some cases, you can get fever. Diarrhea is more common than constipation. So if you do get an EMQ with diarrhea, surprisingly, that still could be appendicitis and not like diverticulitis or anything like that. So it's just important to keep that in mind. And anything that increases the pressure within your gut. So coughing, sneezing, bending over, lifting heavy things, any of that could do that. Signs. Tachycardia, so just having the pain could just make your heart rate shoot up. Abdotendinous with generalized peritonism suggesting perforation. And this is something I got from my SPT tutor last year. What's the most reliable sign of appendicitis? Will, do you remember? Yeah, this is, I'm actually not too sure about it. I literally quoted him because he's been like performing surgery for like 40 years, but apparently it's rebound tenderness. So if you see someone with rebound tenderness, your first diagnosis should almost always be appendicitis before anything else. But take that with a grain of salt, because that might necessarily not apply like evidence-based. It's just from a clinical perspective. Okay, investigations, FBE, technically appendicitis should be diagnosed clinically, so you shouldn't need any of this, but FBE could be done to see if there's any neutrophilia. You can do a CT scan, which is considered the gold standard for imaging, and any other investigation for the differential list. So if you suspect an ectopic pregnancy, do a beta HCG. If you suspect a UTI, do like a midstream urine, things like that. And management is pretty simple, so just remove the appendix. You've got to start them on empirical antibiotics though. What are the 3 antibiotics we use for anything gastric? Sorry? Yeah, perfect, that's 1. There's 2 more. Yeah, and the simple one that we all get from when we get full sick. Amoxi, perfect. So AGM was the way I remembered it. So some textbooks say ampicillin, but I think we need to know amoxicillin from an ETG perspective. So amoxi, gentamicin, and metronidazole is what we use for pretty much any lower GI thing. Bit of fun fact. So laparoscopic approach has advantages, but is apparently not recommended in gangrenous perforation. You need to use like an open surgery approach for that. Don't really need to know that. Just thought it was interesting. Okay. Any questions about appendicitis? It should be pretty straightforward, I think. Definitely can come up as an ENQ. Like I think the classic Monash stem is 18-year-old male presents with acute abdominal pain. FP reveals a neutrophil count of like 25. So what do you think it is? Yeah. Okay. Intestinal obstruction. So when you see someone with a suspected obstructed bowel, there are 3 questions you must think of. Does anyone want to have a crack at what one of those questions might be?
Have you passed bleeding?
Yep. So I'm just thinking from like not like a patient history point of view. Sorry, I can't.
That was it.
Oh, sorry, I couldn't see. Understand now. No, so that's a really fair question. I'm more thinking about it from like a doctor point of view, not like a history point of view. So okay, as an example, like one of the questions I was thinking of is it a large bowel or a small bowel obstruction, like that. So that could be one of the 3 questions. What else do you reckon could be another question? Yeah, definitely. So is it mechanical or functional? Because if it's, so the term is a virgin abdomen. If it's a virgin abdomen that's like never been surgically like sort of explored in any way before, you got to like rule out like say functional causes for that, for instance. Yep. So, and I think the last, so is it an SBO or an LBO? Is it functional or mechanical? And the last one, is it simple, closed loop, or the really bad one, is it strangulated? So do you guys know the difference between simple and closed loop? So I actually didn't know this till I made this presentation as well. Simple is pretty much, there's no vascular supply involved. Closed loop is, it's not technically strangulated yet, but there's 2 points involved. So there could be a potential for like vascular compromise, which could then lead to bad things. Features that can occur in both LBOs and SBOs. So nausea, vomiting plus anorexia. So because you have something obstructing your bowel, you're not going to want to eat anything because you can't like crap out what you've already eaten. So that's pretty obvious. You get colic, obstipation. Do you guys know what obstipation is? So obstipation is pretty much complete constipation. Like in constipation, you can probably pass out a little bit of wind as well. In obstipation, nothing can come out. Like there's no wind, no stool, nothing. You're completely blocked. And buzzword, active tinkling bowel sound. So when you guys do your apto exam, you put your stethoscope and listen for this. If you hear that, that's a buzzword for bowel obstruction. So general principles of management, the drip and suck, which is you want to get a nasogastric tube in as well as IV fluid. So you don't want to make them eat anything, but at the same time, you got to make sure that they're not going to like die from malnutrition. And nil by mouth as well. And further imaging. So you could start off with an AXR or a chest X-ray just to see if there's any free air that's come up there. The main thing you should do is don't do a colonoscopy because there's a risk of literally perforating the bowel that's been obstructed and then like bacteria can spread everywhere. Oral gastrographin, so the little white liquid that people drink, is also quite useful, and that can both help the level of obstruction, and it's said to be therapeutic as well, so it can also help relieve some of the obstructions. So that's another thing. Main things though, if you're in an OSCE and this comes up, make sure you state that colonoscopies would not be done because there's a risk of perforation. And this applies for anything in which your differential is an obstructed bowel. So if you're like doing diverticulitis and you suspect like it could be an obstructed bowel, mention you wouldn't do colonoscopies because you risk perforation. And surgery, yeah. So if they're strangulated, do the surgery immediately. Otherwise, they're going to die. Okay, so the image is not the best there. Do you guys want to have a crack at which one's large bowel, which one's small bowel, and which one's special, like a bonus point? So you have valvular caniventes that completely cross the lumen in number A. Would that be a large bowel one or a small bowel one?
Small.
Okay, we seem to have small. It is small. The second one, you have peripheral gas shadows proximal to the blockage. So you have gas behind the blockage and you have nothing in front of the blockage. What's that going to be? Yeah, so that's some very classic large bowel. So literally there's going to be a point where there's gas before it and there's stool after it. And that's the point where the blockages occur. And the last one, you have a classic, you have a classic copy V sign. That's your sigmoid volvulus. So like just again buzzwords. I doubt they're ever going to say coffee bean sign in an EMQ, but if you do have it in like an OSCE, you can just point out the coffee bean and the examiner will be like, aha. Okay. So mechanical SPOs, with regards to the pathophys, there's a mechanical obstruction that causes accumulation of gas and fluids proximal to the site of obstruction. So if everything's going that way and I have an obstruction there, everything's going to start accumulating there because nothing can go there. Pretty straightforward. As a result of the obstruction, your intestines start working overtime, and that's why you get the little tinkly sounds, because your intestines try to like literally push everything out. And that manifests as diarrhea and chronic pain. If you constantly have the increased pressure and nothing really is allowed to get out of your body, your blood vessels can get strangulated, and that's what leads to intestinal ischemia and necrosis. And that's the surgical emergency part. So you have to get rid of the diseased bowel by then. Causes of SBO, does anyone want to have a crack at what some of the most popular causes are? Or just what the causes are in general? Adhesions, perfect. So adhesions, I think, is the most common cause, yes. The mnemonic I used for this is shaving. So strangulations, hernias, adhesions, volvulus, interception, neoplasms, and gallstones. So by far, if you have to remember one of the 7, just remember adhesions. Like, it's like surgeons like love it when you mention adhesions as a cause of small bowel obstruction, but don't mention it's their adhesions. Like I think last year I accidentally told the surgeon adhesions, and I was like, "Oh, did you do it or something?" Yeah, that was not good. Okay, but yeah, adhesions is by far the most common cause. Gallstones is a bit of a rare one, so I'm sure you guys would have heard of gallstone ileus. Yeah, so that's essentially a fistula between the gallbladder and the intestine, so a cholecystoenteric fistula that causes the gallstone to like lodge in the small bowel, and that's pretty bad. So yeah. Okay, clinical presentations, vomiting. So the main one you see is they literally vomit poo out. So fecal vomiting is seen particularly with intestinal obstruction within the ileum, and vomiting is more prominent with proximal. So the higher up you go, the more likely you are to get it out from the top. Like if it's something at the bottom, it's not going to regurgitate all the way up. And you get colicky, abdo pain, nausea, vomiting, can get obstipation as well. Signs, so as we said, you're going to listen to your bowel, you're going to get the hyperactive bowel sounds, and eventually your intestine's just going to tire out from working so hard, you're not going to hear anything. Tachycardia, you're going to get abdotendinous, fever, potentially, and a marked white blood cell count rise as well. Okay. Investigations, so you get FP electrolytes. Do you get metabolic acidosis or alkalosis? So it's alkalosis in this case, and that's because you're vomiting everything out. So if you're vomiting all of the electrolytes, you start losing like the electrolytes, and that's why your faces go up. Yeah, and for some reason, amylase can be elevated as well. I'm not too sure why, but that can be elevated. Radiologically, abdominal X-ray is more than sufficient. You look for air fluid levels. Again, a buzzword for small bowel obstructions. You can do a CT scan, but the main reason you do that is just to rule out strangulation. It's no more sensitive or specific than an abdominal X-ray. An upper GI series is pretty good as well, but this is done as a last resort because we mentioned that it's sort of therapeutic in a way. So you can do this, but last resort by far. MRI or ultrasound in pregnant patients considered risk versus benefit though. So obviously you don't want to expose them to like too much of like neither of these have radiation, but again you want to like consider the risks of like pregnancy and things like that. Management, drip and suck. So NGT in the stomach helps with gastric decompression and it reduces the risk of aspiration as well. If it's a partial small bowel obstruction, there's not really much you need to do. You literally wait for 48 hours and hopefully everything should be fine. If it's a small bowel obstruction with a history of surgery, this is where adhesions come in. So again, you literally wait for 48 hours because the more surgery you do, the more likely adhesions are going to form. So you just want to sort of watch and wait and ensure that nothing bad happens in the meanwhile. If it's a complete small bowel obstruction, that's pretty damn bad. So get surgery ASAP because if you wait, they're going to like die. So yeah, get surgery ASAP. Okay, any questions? Yeah, sorry.
So what's an upper GI series?
Upper GI series is like sort of manometry, like so you drink and you can sort of image like the liquid going down. Yeah.
Sorry.
Yes.
You said it was the last resort if it's also therapeutic.
The what do you call the series one?
Yeah.
Yeah. So I think think the reason why I wrote that was an abdominal X-ray should be sufficient enough for investigating it. You shouldn't really have to do an upper GI series, and the reason why it's a last resort is it's therapeutic as well. Does that sort of make sense? Sorry, have I gone around in circles? Or?
No.
Yeah, because such a thing should be diagnosed with an X-ray. You don't really need to even consider a GI series, but the reason you do that is not for investigation, it's more for the therapeutic benefit of it. Okay. Cool, any questions about mechanical SBOs? Okay, functional SBOs, thankfully, is much, much simpler. It's temporary and it's a reversible impairment of intestinal motility, and it's often caused by medication. So we often hear constipation as a result of opioids. That's a functional obstruction. It's not like the opioids physically blocking your food from going through. Anesthetics can do it as well, and some psychotropics can do it. Only one clinical feature differentiates functional to mechanical. Does anyone want to have a crack at what this might be? It's the bowel sounds. So the bowel sounds are diminished and absent completely in functional because it's a functional nerve cause, whereas in mechanical, you're sort of trying to like push it out. That's why a bowel sort of goes into overdrive and then dies down. So that's the main difference. So again, this isn't really helpful. Like if you see a mechanical person like 5 days after they present, like if they're not dead yet, their bowel's still going to be like not functioning. So it's not the best way to differentiate, but I think it's a good way to like have like a pattern of reasoning. Investigation. So if this occurs after surgery, it's incredibly common. You don't need to do anything. That's because the bowel's just sort of adapting to the changes after surgery. So you don't really need to stress about that. If ileus persists, review their medications. If they're on endone or any other opioids, try and stop that. Try and get them on something else. Check for like any problems with their electrolytes. So if they're calcium, magnesium, phosphates like all over the charts, and do a CT scan and rule out any sort of mechanical causes. I think the treatment for this is oh no, that was for the large bowel obstruction, sorry. So treatment for this is just don't give anything by the mouth because nothing's going through, and just do fluid resuscitation. Apparently chewing gum helps with like your gut like getting stuff out, so just encourage gum chewing and encourage opioid antagonists. So opioid antagonists, is that like buprenorphine and things like that? Is that methadone?
Buprenorphine is a
Oh, yeah. It's an agonist, is it? What's an opioid antagonist then?
oh
Naloxone. Yeah. So like naloxone and like naltrexone and things like that. Yeah. Yeah. There's just one slide on this. It's not that common. You don't really need to know too much about it. Just know that it exists, pretty much. Okay. Mechanical LBOs is probably as important as mechanical SBOs. Main cause of this is for SBOs, main cause was adhesions. Main cause of this is cancers by far. So adenocarcinomas. I've got a really detailed table here sort of talking about causes inside, outside, and really outside. Don't need to know that. Just know like cancers are the most common cause. The mnemonic I used for this was ABC. So adenocarcinomas, I can't remember what B was, and I can't remember what C was constipation. Yeah. What was B? Was it foreign bodies? I can't remember, yeah. But yeah, so just remember cancers. You don't need to really know anything else. If you want to go into a little bit of detail, there are two main types, and that's dependent on the competency of the ileocecal valve. So if the valve is sort of incompetent, it's an open loop one, and sort of stuff comes back into the ileum from the large intestine, and therefore the clinical presentation is the same as small bowel obstruction because stuff is coming back into the small bowel. The second type is a more common type, and that's a closed loop one. So closed loop ones are the ones you're going to see clinically. Treatment, surgery. So pretty much remove the bowel that's been affected and create like a bag for the time being. And if it's a volvulus, you got to decompress it as well. So that's the only thing. Okay, functional LBOs. So again, just one slide on this. It's not that important. It's called Ogilvie syndrome. I thought that was cool to know. Again, like functional SBOs, we don't really know the cause, and we're assuming that it's an interruption of parasympathetic tone. So we know that the reason why we digest stuff is because we have parasympathetic supply. We're assuming a functional LBO is because we stop that parasympathetic supply. That's all. So since we're stopping the parasympathetic supply, how do you treat that? Not a trick question.
Parasympathomimetics.
Exactly. So you want to give something that will stimulate the parasympathetic system. And going back to your first year neurotransmitter drugs, what do you think this could be? It's the one beginning with N. He's in the Matrix. Neostigmine, perfect. Sorry, that was a very bad way of getting to it. But neostigmine is it's a cholinergic drug, so it's going to stimulate the parasympathetic system. So that's apparently indicated. Literally, it's again a watchful waiting thing. Like if you watch and wait and things sort of resolve on its own, you can just step back. X-ray is more than enough for it, and the symptoms are as follows. So you guys can go through that. That's all for bowel obstructions. Any questions on any of that? Cool. Okay. Intestinal ischemia. Which cardiac condition is this most commonly seen with? Anyone have a crack? Is that you going through the heartbeat? Do you want to have a crack? Yeah, perfect. So the way I learned intestinal ischemia was pretty much a stroke of the stomach. So atrial fibrillation plus abdomen pain is almost always intestinal ischemia. Like there could be other causes, nothing's black and white, but like 95% of the time it's going to be ischemia. And there's three main types of bowel ischemias. So I don't think you guys need to know this in too much detail, but so there's acute mesenteric ischemia, there's chronic mesenteric ischemia, and the last one is ischemic colitis. So the big ones you need to know are 1 and 2, 3 sort of just there for completeness sake. So acute mesenteric ischemia involves the small intestine, and like the name suggests, it's a thrombosis of the artery. So you're not getting blood supply to the intestine, and that's why you start getting the ischemia. So it's SMA thrombosis. You can get mesenteric vein thrombosis as well, and then if you're just predisposed to like Virchow's triad, you can get congenital hypercoagulability. What's the main buzzword that Monash likes to use for this? Have you guys come across it at all? So the buzzword for Monash is like pain out of keeping with clinical findings. So if someone has a ridiculous amount of pain that doesn't really correlate to clinical findings, that's, according to Monash at least, that's intestinal ischemia. So the triad is acute severe abdominal pain, no clinical signs, and in very bad cases, they can go into shock as well. Pain out of proportion to clinical signs, that's in blue. Oh, by the way, just for reference sake, blue and not bold is important. Blue and bold is very, very important. Like learn the blue and bold bits if you can learn anything. That's going to get you through this year. And bold is kind of midway. So initially, an abdominal X-ray shows a gasless abdomen, and you can also get lactate. So lactate dehydrogenase is going to start rising because you're having depth of the cells there. So that's like a buzzword sort of thing you need to know about. Treatment, surgery, just resect. Chronic mesenteric ischemia is over time, instead of having a one-off thrombus, you have diffuse atherosclerosis, and that can just sort of reduce blood supply there. So it's atherosclerosis of the superior mesenteric artery, the inferior mesenteric artery, and apparently something called the middle mesenteric artery, which according to when I was doing the slides, I researched, it doesn't really exist, but all of the textbooks say it does exist. So I doubt you'll get a question on it. Just know that it's a thing of everything affecting the mesenteric arteries. Again, there's a triad for this. It's not as important as the first one, but it's pretty much you get abdo pain after you eat. There's loss of weight because you're stopping eating, you literally can't eat anything, and you get an abdominal bruit. So similar to an aortic bruit when you're looking at the aorta and things like that, you get an abdominal bruit. Investigations and angiography is good here because you're checking the blood vessels, and that can either be a CT or an MR angiography. And treatment is not surgery, but rather revascularization. So if you get the blood supply back to the intestines, that should be enough. You don't really need to do any surgery. And the last one is ischemic colitis. So ischemic colitis, it's lack of flow through the inferior mesenteric artery. And again, like the second one, treatment is not surgical. It's literally conservative management. You give them fluid replacements. You might consider antibiotics, but unless there's gangrene, there's chronic gangrene, you don't need to do surgery for this. So surgery is only for the first one. Okay, Crohn's disease. You guys would have definitely come across Crohn's. You guys have had the GIT path exam before. Okay, perfect. There's a whole heap of buzzwords here. That's a little bit late now, but it'll be good for the exam anyways. What is Crohn's disease? Does anyone want to give me a definition? So Will just pointed to his bum and up to his mouth. So does that give you guys any clues? Perfect, perfect. That's a very good start. That's better than what I did when a colorectal surgeon asked me to define Crohn's disease last year. Like I was just like, it's a disease of the intestine. He's like, why are you here? Perfect. So it's one of the two inflammatory bowel diseases. Is there anything more you could tell me, Colin?
I get the concern.
Sure. Okay, we're going straight to pathology. Does it affect one particular region or does it affect every particular region? Yes, perfect. So gum to bum was the way I learned it. Mouth to anus as well. So I think so I split it up here. So what is it? It's a chronic inflammatory non-caseating. So non-caseating simply means non-necrosis. Granulomatous, so there's a presence of granulomas. Transmural, so it affects the entire lumen of the intestine, affecting any part of the GI tract, so from gum to bum. So in terms of most commonly affected area, it's the ileocolon, but it can affect any region there. Epidemiology, unfortunately fairly common. There's more than 80,000 people living with this condition. The prevalence is probably about 200. And unlike UC, this is highly associated with smoking. So easy risk factor to remember. Etiology, like pretty much almost every autoimmune disease, we don't really know what causes it. Multiple factors involved. Risk factors include zinc deficiency. I remember back in second year, we got like a weird question on zinc. That's why I've like bolded it there. Like if they ask you some question on zinc, just know that Crohn's is like related to it. And apparently NSAIDs can cause Crohn's as well. So yeah. Okay, buzzwords. So this is, I'm just gonna get the entire slide up there. Inflammatory infiltrate around the intestinal crypts. So I'll go through crypt abscesses for the other one. Inflammation progresses, forms non-caseating granulomas, and this is a massive buzzword for Crohn's. Cobblestone appearance, as Colin rightly said. So inflamed mucosa makes the cobblestone appearance, and you can get skip lesions. So you can get areas that are nice and then areas that are affected. And the acute inflammation results in bowel obstruction, and the chronic inflammation can result in scarring, narrowing, and strictures. So strictures is, again, a big thing associated with Crohn's. And lastly, you get something called fat wrapping as well. And I've explained why fat wrapping occurs in the last sentence there. So you can just go through these slides in your own time. Complications. Small bowel obstruction. Yeah, perfect. So that's one of the big ones. Parts of the bowel can narrow over time. You get diffuse ulcerations as well. So the big one that Monash likes you to know is aphthous ulcers in your mouth. You can also get ulcers in and around your anus and your perineum. Fistulas. Perianal fistulas are the most common type. So no, you don't need to know about fistulas too much. The main place you'll need to know fistulas about are in diverticulitis, but know that perianal fistulas are common in Crohn's. Anal fissures as well. So you need to know how to differentiate between a skin tag and an anal fissure from like a hospital point of view. So if you're in colorectal or gen surg, like a skin tag is something that's sort of non-like pathological. It looks kind of innocent, whereas an anal fissure you can obviously see like looks pretty damn like inflamed there. So just know that. And malnutrition. So pretty simple. If someone has Crohn's, you're not going to eat as much, and then like they're going to get malnutrition. Crohn's is one of those things which, since it can affect any region of the gut, you constantly have to do surgery after surgery, and this can result in something called SGS, or short gut syndrome. So your gut's like initially like 6 meters or 20 feet long, and over time it'll just shrink because you're cutting it off. So yeah, and that's a surgical complication. EI manifestations of Crohn's disease. What are some things you see outside of the intestines, the stomach? So there's 2 skin conditions that Monash really likes you to know for this. Wait, someone saying it?
I'm sure. It's like everything.
Perfect. That's one of them. And the other one beginning with P?
Yeah.
No. So it's pyoderma gangrenosum, which is again buzzword. What's the one that affects the eyes?
Uveitis.
Perfect. Anterior uveitis. Yep. So just be a little bit specific about that. That's perfect. And I'm sorry. One of the last complications, you get cancer as well. Yeah, pretty bad. Okay. So pyoderma gangrenosum, erythema nodosum, which you rightly said. PBC is a big one. Angst-Bond, and Angst-Bond is one of those things that results in your anterior uveitis as well. Polyarthritis and chronic hepatitis. So PBC and chronic hepatitis are very closely related there. Okay. Investigations for Crohn's. Investigations for Crohn's, like what's the basic investigation you guys would do if someone comes into the hospital with like suspected Crohn's? Sure. Like, I was gonna say like bloods and everything, but you've jumped straight to like the big things. That's very valid. So colonoscopy is by far the gold standard. So if you're like doing one of those consent stations, like you guys have done consent like OSCE practice a little bit, yeah. So be familiar with like IPR and things like that. But colonoscopy with intubation of the ileum is like by far the gold standard, and you got to like get a tissue biopsy as well. But again, like it's tissue biopsy is more like it just confirms it, because like if you have the clinical picture, you have the patient and they're like of the right age group and everything, you should probably have the diagnosis as like a first step. You can do an FBE. The main thing that you got to check for an FBE is the HLA-B27 antigen as well, because that's very strongly associated with Crohn's. So just have a look at that. Yeah. Management for Crohn's is, sorry, question.
Really quickly with colonoscopy.
Yes.
If a bowel obstruction is such a common complication of Crohn's, or I don't know if it's common, but like if someone comes into hospital and they don't know they have Crohn's, and they come in because of bowel obstruction secondary to Crohn's, how long do you have to wait before you do a
treat the bowel obstruction, then check for Crohn's? Like definitely don't do a colonoscopy then. I think I probably shouldn't have had bowel obstruction as one of my top for the complications. It's definitely not like the most common one. It can be up there, but it's definitely not the most common one. So like you would treat the obstruction before you proceed with the imaging. Management is very, very OSCEable. Like you could literally have a station where like a patient comes in and they're like, manage this patient with Crohn's disease from both a medical and a lifestyle perspective. So I think it's good to know this half of the slides pretty damn well. So nutrition, so encourage a liquid diet. Crohn's people can't eat solid food because it hurts. So encourage something that's liquids and avoid NSAIDs if they have pain. So something like paracetamol is more than enough. Mesosalazine, so that's one of the immunomodulators you guys would have done back in first year. Can give antibiotics if there's infective symptoms, but don't really need to. Corticosteroids, so the triad they use is pred plus budesonide plus hydrocortisone. So I think if you mention at least one of these, you should be fine. But just know that corticosteroids is one of the ones you mentioned as well. Immunosuppression, so mesosalazine, I think, is an immunomodulator, and immunosuppression sounds like azathioprine and methotrexate and things like that. So, yep. Oh, wait. Okay. I don't know what mesosalazine is then. Well, what is mesosalazine?
I think it's one of the sulfur-based.
Oh, is it?
Yeah.
Okay. I just know that it's like...
It's after corticosteroid.
Is it? This is from Oxford Handbook.
Oh, no.
I'm not doubting you, like...
Just spill it all in OSCE.
Yeah,
say
like
everything.
Like if you say as much of this as possible, you'll be fine. Question.
So, is that you give nutrients?
I think I've gotten given all three there, but like I think in the tension of like an OSCE, if you name one of them, you'll be fine. If you name all three, like, good on you. Like I couldn't do that. But just name at least one of them. And like again, like if you say corticosteroids, that should be enough as well. But just know that you have to give them steroids. Immunosuppression and immunomodulators, and the last one is surgery. So if they have complications and if they're like not having a good quality of life with any of the above five, just do surgery. That's your last resort. Metronidazole, if they have perianal Crohn's disease, so you mentioned the perianal fistulas, you want to give metronidazole for that. And note that Crohn's is prone to relapse, like I said. So treatment is pretty much supportive. It's not going to cure them. In UC, if you like resect the affected bowel, everything should be fine. In Crohn's, that's not going to be the case. So you want to like continue like just improving the quality of life more than anything else. Okay. Any questions about Crohn's in general? Cool. UC. What is UC? You guys want to have a crack? I'm gonna pick on you, Colin. I'm sorry. Actually, no. You did a really good job with Crohn's, Eldon.
It's a disease of the large bowel.
Yeah, perfect. It's an inflammatory bowel disease or not? Perfect. Okay. So just going into a bit more detail, I've got an IBD involving the colonic columnar mucosa that always involves the rectum. This is what differentiates Crohn's from UC, because UC will always involve the rectum and then spread proximally upwards. And UC is relapsing remitting. So it's sort of, there's a flare up and then things are back to normal and then there's like a bad flare up again. Epi, again, 80,000 Australians live with IBD. Main thing you need to remember is there's more people with UC than there are with CD. And risk is less in smokers. So there's a 20% risk of colon cancer, and the other main risk you got to remember with UC is something called toxic megacolon. These are like the two big buzzwords that Monash wants you to know. And we said Crohn's was associated with PBC. UC is associated with PSC. Yeah? You guys know what PBC and PSC are, yeah? Okay, good. Again, with regards to distribution, so always involves the rectum. If you're really unlucky, you can get something called pancolitis, which is everything gets inflamed. But most of the time, it's like sort of the bottom end or like the left side. Scoring systems for severity. So my SPT tutor last year asked me to do this as a task, and I just thought I'd include this. You don't need to know all 4 of them. The main thing I think you need to know is as UC gets more severe, you sort of poo more often a day. It sort of makes sense, but just know that.
Attention met, surgical short stay unit, bed 28, urology unit. Attention met, surgical short stay unit, bed 28, urology unit.
Cool. So the Truelove and Witts criteria is the one that Monash likes you to sort of reasonably know. Again, this is more for like a hospital point of view. You won't really be assessed on this, and it can't really be asked in an OSCE, but just know that there are scoring systems for the severity of UC. Pathology buzzwords. So etiology, again, like an autoimmune disease, we don't really know why it happens. But an OSCE answer could potentially be an inappropriate immune response to normal gut flora in genetically susceptible individuals. So pretty much your body just doesn't like what's going on down there and it just attacks it. So that's a very nice OSCE answer in case you're asked that. Pathologically, you get hyperemic plus hemorrhagic colonic mucosa, so it looks really red. And pseudopolyps is the very big buzzword for Monash. Inflammation is not transmural, unlike Crohn's. And with severe inflammation, you can get the appearance of multiple polyps. So you have pseudopolyps there, but they're actually just apophysis ulcers. When you do a biopsy, you get crypt abscesses. So for the other one, you do get crypts, but there are no abscesses in it. Whereas in UC, you get crypt abscesses, as well as the atrophy of crypts themselves. Complications of UC. So we've been through the main 2, which are, so what were the main 2 complications? Cancer and
Toxic.
Perfect. So these 2 are like the big ones you need to know. Toxic megacolon is, so I for the longest time thought that if like you have to like surgically treat it, but you just like you don't surgically treat it. You like do nil by mouth and NGT to decompress it. Like surgery is like literally a last resort. So just remember that when you're learning this. And yeah, you get decreased potassium as well and long-term risk of colonic cancer. Clinical presentation, more than often, it's like a sort of young male or female, probably late teens to early 20s with non-bloody diarrhea. And that should be frequently, sorry, not frequency. Non-bloody diarrhea is frequently the initial presentation, but the more you go to the toilet every day as you become, like as a disease sort of worsens, that's when the diarrhea becomes bloody as well. Rectal bleeding is the main feature that you're going to see. And extraintestinal manifestations, thankfully, are quite similar to that of Crohn's. So erythema nodosum, peripheral arteritis, angst-spawn sacroiliitis, you get uveitis and sometimes episcleritis, so eye, and you can get clubbing as well. So these are the big ones you gotta know. Yeah, you guys can look at that. So this is like a very detailed way of learning the complications of IBD, but I feel it's just good to know that when you're learning. So investigations, more or less pretty similar to Crohn's. So you do a stool study. This is the big one that separates Crohn's from UC. You look for something called calprotectin, which is only seen in UC. So do this when you're suspecting UC. FPE antibodies. So again, buzz. UC is linked to PSC. PSC is linked to P-ANCA. What kidney condition is P-ANCA related to as well? So I think from memory, it's Wegener's, and C-ANCA was the eosinophilic one.
Well, P-ANCA is Church-Strauss.
Oh, it's P-ANCA Church-Strauss. Okay. Okay, so C-ANCA is Wegener's, and P-ANCA is eosinophilic GPA, also known as Church-Strauss. So got to remember that. And Crohn's is linked to ASCA. So These are like very classic Monash buzzwords that come up in the past, so I think it's good to know this. ASCA, I think, is I can't remember the full form, but wait, do I have it in my slides at the bottom? No, I don't. I can't remember what it stands for, but I just know that it's related to Crohn's. It's like buzzword for Monash. It's one of the antibodies as well.
Oh, okay.
Yeah. Colonoscopy, so indicated in patients with UC who are not responding well to treatment, and it's good to like sort of exclude Crohn's as well because they sort of overlap quite a lot. So it's just good to like you do a colonoscopy to exclude both. So again, treatment is mesosalazine like Crohn's and topical steroids, and you might consider immunomodulation. But the main thing to remember with a UC, unlike Crohn's, is like UC sort of affects a distinct area. So if you're really lucky and it's not pancreatitis, just do surgery. So about 1 in 5 of all patients just get surgery, and this pretty much removes all symptoms. So that's a pretty good option to consider. And these are the types of surgeries you can do. So the big one you got to remember is number 2. So panproctocolectomy is removal of the colon, the rectum, and the anus. And since you're removing everything, you can't have a risk of colorectal cancer. So it's a permanent option, and you just don't have a risk of cancer. And the same for a total proctocolectomy as well. You can also do an abdocolectomy, which is used in severe colitis, but not really. This is just like a lot of detail. Just, yeah. Complications of surgery. So like any surgery, it's good to know a couple of the common complications. So you can get functional bowel obstruction. So that's a postoperative ileus. Dehydration, because your stoma is literally collecting fluid and you can start to lose a lot of fluid there. And anastomotic leak, which is where the anastomosis between the intestine and the other intestine of the bag is not good and you're starting to leak out nutrients. Strictures, fistulas, and pouchitis. Pouchitis is literally an inflammation of the region where the stoma was created. Okay, you guys can go through that in your own time. This is like quite buzzwordy, like particularly the radiological features and the histological features. Know that that's like a lot of buzzwords there. Okay, diverticular disease. We're nearly there, guys. So what is diverticular disease? Does anyone want to have a crack? Claire, I'm so sorry.
Well, I know it presents like rectal bleeding, and it's like pouches.
Yes,
like
exactly.
Within the colon.
Exactly. So I mistakenly thought diverticular disease was like a hernia of the colon because it was literally an outpouching of the colon, but it's slightly different. But like you literally said, it's an outpouching of the gut wall, usually where there are perforating arteries. So perforating arteries occur at sites of muscular weakness, and this one just like literally outpouches at that particular site. So diverticulosis means diverticular present. Diverticular disease means that diverticulosis itself is symptomatic, and diverticulitis is an inflammation of that. So I think it's good to know just the subtle differences between these three. Epi, not really much to know. Apparently 95% of left-sided cases are Western countries, 75% of right-sided cases are Asian countries. That's like the big thing I was told. Apparently vegetarians have a lower incidence. So like in someone with diverticular disease, you want to encourage a high fiber vegetarian diet, like just avoid meat at all costs. That is, yeah, you don't need to know that. That's just there for completeness sake. So the Hinchey staging is the one that he used for determining the staging. And it's used to determine the degree of infection. That's why you have the staging thing. So in the first stage, there's an abscess, but this is sort of like, it's not really going to affect the body systemically. Again, the second stage, it's a walled off abscess, so it could resolve without surgery. Third and fourth stages are like the abscess is sort of spread everywhere. So you get peritonitis, and that's when you need surgery. Bonus points, what's the name of the surgery you need, the eponymous name? Begins with H. Hartmann's, perfect. So Hartmann's is like the big one that pretty much all colorectal surgeons do at some point. It's also known as a proctosigmoidectomy, which is a resection of the rectosigmoid colon with closure of the stump and formation of a bag there. And that's what it looks like. Etiology, yeah, so anyone with low fiber intake, so like just a lot of red meat without any fiber, and anything which can alter the wall of the colon. So this can include connective tissue diseases. So yeah, I've got a fun fact there. So Ehlers-Danlos syndrome can cause a triad of diseases called Saint's triad, which is a hernia, diverticular disease, and gallstones. Like 3 things that are completely unrelated to each other but can occur in the presence of one disease. So, yeah. Pathophys, anything that increases pressure causes the outpacking to occur. So really similar to hernias, like anything that increases the abdominal pressure causes stuff to come out at a site of weakness. And it's most commonly where the arteries penetrate the muscular layer. So since it's coming through the arteries, you have a risk of hemorrhage as well. And that's why, as Claire rightly said, one of the biggest things you see is painless painless bloody diarrhea, because you're not going to feel anything, but you're just going to pass a lot of blood when you poop. Complications, colitis, so you can get inflammation, GI bleeding, and an abscess. Perforation is characterized by lack of movement of your intestines with shock, if it's really bad, and fistula formation. So what's the most common fistula you get with diverticular disease? Buzzword. So if you get bubbles in your urine, what's causing the bubbles? So where in your abdomen would you have gas? That's what I'm trying to get at.
Fistula to the bladder.
Yes, so a fistula from where to the bladder?
Out of the bladder.
Exactly, so it's a colovesical fistula. So like the sign of this is called pneumaturia, which is bubbles in urine, and it's literally something joining your colon to your bladder. Okay, clinical presentation, we'll just quickly go through this since I've already kept you here for quite long. Painless rectal bleeding with a feeling of wanting to poo at all times. That's the most common thing you see by far. But apparently it's quite asymptomatic. So in a lot of cases, you don't really see much. Diarrhea is the main presenting complaint. And if you palpate, they're going to feel tender as well. Investigation is fairly straightforward. So an abdominal x-ray is decent, but a CT scan is the best. So since it's an outpouching and you see like a mass there on imaging, it can often be confused with colorectal cancer. So it's important to sort of differentiate between both of them. And yeah, that's pretty much it. Okay. Diverticular disease, main thing to remember with treatment is you don't need to do surgery unless things are really bad. So if it's uncomplicated, don't need to do anything at all. Just tell the patient to eat diet rich in fiber, so things like wheat, bread, all of that. Diverticular bleed, if the bleeding doesn't stop, you've got to cauterize and resect that area. If it's diverticulitis, don't need to do surgery again. Just give them metronidazole if they're an outpatient, or if they come into hospital, AGM, that's enough. And if it's like a complicated case of diverticulitis, that's when you might consider surgery. Yeah? So,
avoid nuts and corn.
Sure. Really?
This guy at the community center, he had diverticulitis and he had to go to the hospital because he ate like a lot of nuts and corn on the same day.
Oh, yeah, I eat a lot of nuts and corn. That's great.
I was also have diverticular disease.
Yes. Okay. Avoid nuts and corn as well. I'll include that in the slide stuff. Thanks. And the main thing you got to remember, apart from not doing surgery, is recurrence is really common. So if someone has one episode, they're probably going to get it a second time. If someone's had a second episode, they're almost definitely going to get it in the future. So yeah. Okay. Last big one: colorectal cancer. Majority of colorectal cancers are adenocarcinomas. 70% from colon, 30% from rectum. Unfortunately, really common in developed countries, so just know that the epi is like pretty shocking. I was doing some, when I was making these slides, I was just looking at my notes, and I think it's good for you guys to know these stats because this could like very easily come up in an OSCE. So with regards to cancers, what's the most common cancer for males and females under 25? So what cancer affects kids? Sorry, did someone say? Perfect, yeah. So leukemias are the big ones. For women who are sort of, for women who are like sort of between 25 to 50. No, surprise. So women specifically. So this was surprising to me. It was breast cancer and melanoma for men. For women between 50 to 65, again, it's breast cancer and it's prostate cancer for men. And for anyone above 65, that's when this one comes in. So it's colon cancer there. No worries. Catch guys. So I think it's good to know that just for a little bit. Again, can be asked in an exam. Second most common cancer in Australia, second most common cause of deaths as well. So yeah. So do you guys know the staging for colorectal cancer? So how would you stage cancer? Like there's two ways of stage. There's one way of staging like all types of cancers, which is TNM, perfect. And the other one specific to colorectal cancer? Dukes, perfect. Yeah, no, exactly. So Duke staging, which is to determine 5-year survival, and TNM staging, which is sort of general to all cancers. So that's what they both look like. Don't really need to know it in detail, just know that it exists. Etiology, unfortunately, 95% of cancer occurs in people with no risk. I'm just going to quickly skip through this. Genetic risk is the big one. Obesity can apparently cause it as well, and if you eat a lot of meat. So like red meat is associated with it. Other stuff that can predispose it. So if you have familial adenomatous polyposis or Lynch syndrome, so hereditary non-polyposis colorectal cancer, I think the CCs are. Yeah, Lynch syndrome. So those are like things that can predispose you to it. If you smoke, it can cause cancer, and if you've already had a previous cancer. So classic Monash question that they like to ask is, there's a 73-year-old Serbian woman who had a cancer that had gone to a liver with like a past history of people in a family who had died with cancer as well. What was her diagnosis? The diagnosis was a colorectal cancer that had actually metastasized to the liver. So this is like classic Monash questions, but good to know that. And apparently, if you take aspirin every day, it reduces mortality. Pathophys, you guys can read this in your own time. Pretty much something that's very nice and simple initially becomes cancer. And those are the stages through which it goes. In 80% of cases, the tumor suppressor gene is responsible for both stopping apoptosis and increasing cell proliferation. So two things that can together make cancer bad. Clinical presentation. Surely you guys would have seen at least heard about some people who've come with cancer. What would you guys see in the hospital setting? Sorry, what would you say, Alden? Blood and stool, yeah, perfect, Hannah. Anything else that you guys might see? Weight loss, perfect. So classic cancer symptoms: fever, weight loss, night sweats. You're going to see all of that. Blood and stools is a big one as well. And then if you use a little bit of logic, people are not going to eat as much because they feel uncomfortable. So weight loss, that way decreased appetite and all of that. So any individual with an unexplained GI bleed or unexplained anemia who's over 60 must have a colonoscopy done. This is the red flag. You have to do it because they might have cancer that's undiagnosed. Monash buzzword again, if you have a proximal cancer, you're more likely to get diarrhea. If you have a distal cancer, you're more likely to get constipation. Yeah. And 20% of patients have got Mets by the time you see them. So consider the breast, consider the brain, consider the liver, things like that. And consider paraneoplastic syndromes as well. That's really important to know. Investigations. What's the tumor marker for colorectal cancer? CEA, perfect. So carcinoembryonic antigen is the big one. There are other tumor markers which I think you guys should probably learn for other specific cancers as well. So things like pancreatic cancer, I think is 19.9 or something. Ovarian cancer is 125. It's good to know this. There's a nice table on Oxford Handbook which literally documents this. Definitely learn that. FBE. So if they have anemia, you want to check what sort of anemia it is. Colonoscopy plus biopsy is gold standard. So you want to check if there's a tumor there. And the sign you get is the apple core sign. So I think in 2014, one of the questions was they gave you an x-ray in the exam and they're like, what does the patient have? And there was a massive apple core sign there. So yeah, just know that. Management, surgery. So just a whole heap of surgeries. I've got that in blue there because a high anterior resection is the most common surgery they do. And the reason it's the most common surgery is that region is the most commonly affected region in colorectal cancer. So that's why they do that. But this is, again, a lot of detail. But just know that surgery has to be done. And you'd counsel the patient on common complications. So things that can leak out. You can get ileus, you can get DVTs, PEs as a result of surgery. Just common sense there. Okay, and chemotherapy, of course. So give them 5-fluorouracil for Dukes B and C. It's also good to reasonably know a little bit about the FOBT, so you guys can just go through the slides later on. But yeah, that's pretty much it. The main thing you got to remember is FOBT is a pretty crap test. So if you have a lot of meat in your diet and you shit blood out, the FOBT will register that as a positive sign. So you just got to remember that it's not confirmatory, it's just going to point you in the right direction. That's it. Okay. I was hoping to go through this, but you guys all look cooked, and I want to give you some break before your ethics thing in the next 45 minutes. So you guys are happy to go through this in your own time, right? Literally, again, as I said, anything bold is buzzwordy. So just go through the buzzwords and like know like the common things. Let me just think if there's anything in particular that I want you to know. Anal fissure is fine. Like all of these. So what I've done for these conditions is, you know, those EMQs, you get like a whole heap of perianal conditions. I've included every single one here with like a little bit of important information. So if you get a question, you can hopefully know like how to approach it. That's fine. Internal, external hemorrhoids. Which one's painful out of these? External, perfect. And that's pretty much all you need to know. Also know the dentate line. So you guys remember the dentate line you learned last year? Just know a little bit about like the blood supply above it, blood supply below it, lymph above, lymph below, things like that. Anorectal abscesses, proctalgia fugax. Main one is if you're giving them topical GTN, you can get headaches as a result of that. So a common question you get is someone comes in with a headache as a result of this condition and this medication, what did they have? So just remember that. And pilonidal disease is, again, fairly straightforward. It's literally hair around the pilonidal region. Your first line treatment is ensure hygiene of the area. If that doesn't work, then you want to consider something called marsupialization, which is surgery. So that's all mentioned there as well. Yeah, are you guys happy to do like 5 questions, or are you guys cooked? Okay, cool. We'll just finish on a high note. Questions? Anyone can like, we'll do them in order. So the first one. If you guys want to raise hands, then I'll just pick one.
I didn't finish reading the options, but
No, go ahead.
Appendicitis.
Perfect. So like hopefully the first one is one of those things where you don't even need to see the option. It's like very classic, like young teenager with pain, acute pain, appendicitis. Perfect. Next one. Alcoholic male, 8-hour history of epigastric pain and vomiting. Okay, I've got one by one. Yeah, so I've got acute appendicitis and acute pancreatitis. Any questions with that? Well, pretty straightforward. Are you guys happy to move on? Or? Cool. Easy peasy. Okay. This one was slightly controversial. I'll let you guys go through it. But yeah, we'll go through the first one. Anyone want to have a crack at number 6?
Is it pelvic abscess from anastomotic leak?
I didn't. So pelvic abscess or anastomotic leak, you said. Wait, is anastomotic leak an option?
Didn't he get a right hemicolectomy?
Okay, I think this was the one that was slightly. Was this the one that was controversial? Let me double check. Yeah, so this was the one that was controversial. So I actually went with UTI for this, and I spoke to Will as well, and I could not for the life of me find the faculty answers. So I think this particular question probably take with a grain of salt. The reason I went with UTI is pelvic abscesses. If it's an abscess, you got to get swinging fevers, and from what I see here, it's like a constant high fever. And the other thing that pointed me to UTI was he was delirious. So in people who are that old, a UTI is going to cause delirium. So that's why I considered that over a pelvic abscess. But again, this was slightly contentious for me, so just ignore this one. Next one should probably be a little bit more straightforward. Okay. Actually, no, I think next one was a more contentious one.
Why did abscesses give you so many fevers?
I'm actually not sure why. I just know that they just do, and it's a very classic Monash buzzword. Like anytime you see the word swinging fevers, the answer has to be an abscess for Monash. I'm not sure about the pathophys. I think it's probably because the bacteria sort of come and go with an abscess before they become constant. Maybe that's why, but I'm not too sure. Sorry. So 17-year-old male with a drain tube. Anyone want to have a guess for this one? I think 7 was like the hardest one that like I was like very, very unsure about.
Would be like a wound infection.
I actually went with wound infection for this, I'm pretty certain. Okay, yeah, so the reason why I went, so did anyone else have a different answer first off? Okay, so I was actually tossing up between like, say, I think it was pelvic abscess for this and wound infection. The reason why I picked wound infection was there was nothing coming out of the draining tube, and with an abscess you expect pus and crap to come out, so that's why I didn't go with that. Okay, hopefully more straightforward ones from now on. Obese 45-year-old male.
Attention Met, 5F North, bed 24, Gen Med A unit. Attention Met, 5F North, bed 24, Gen Med A unit.
Okay, does anyone want to have a crack? Matt, I'm going to pick on you, sorry.
I was thinking about this.
Okay, perfect. I think that's what I put as well. No, wait a minute.
It's radiating to the
Oh, wait, no, it's radiating to the back.
Oh.
Yeah, so I,
Then it'd be due to gallstones.
yes, so I think, once, let me just read the question again. That's associated with 1 episode of vomiting, multiple episodes of retching. Yeah, so I think the reason why, so this is again slightly contentious. So the reason why I put pancreatitis was I put this as pancreatitis caused as a result of gallstones. Yeah, so that radiating to the back you don't commonly see in gallstones. Gallstones is more like the classic Boas sign, like the shoulder scapula. So that's why I went with pancreatitis here. Do you guys know the 5 F's of cholecystitis, right? So it's like fat, female, 40, fertile, fair, which is Caucasian. Yeah, so just know that. Okay, 6th question. We've got 4 more after this. Home stretch. 65-year-old male, left lower abdo pain, slightly obese, 30-pack year smoking history. Is cancer an option?
Is it?
No, it's not.
Aww.
I mean, with 30-pack year smoking history, fair enough. That's cool. Okay, I'm hearing some whispers.
It's definitely adopted pregnancy.
Hey man, he's 65. Don't judge his life. He can live the way he wants.
For pregnancy, yeah.
Yeah, of course.
Being male.
It's 2019. Yeah, anything can be done. Technology's come a long way. All right, no, just in the interest of time, like I want to let you guys leave like reasons here. Morgan, do you want to? Yeah, I'm pretty certain that's what I put. Yeah, straightforward. Okay, 4 more. So 2 here, 2 on the next page. 55-year-old journalist with massive loss of weight and just feeling crap overall. So we're hearing cancer. Is that what I have? Yes, so cancer of the stomach in this case, but perfect. 36-year-old male, 3-week upper abdo pain coming after eating. It's also pointable, like you can point where the pain is. I think that's what I had, Hannah. Yeah, perfect. So just go through the questions in your own time, but like everything points to like a very sort of classic gallbladder picture. And again, another buzzword from Monash. If you see a question with a 49-year-old salesman in it who gets like crazy after a hospital admission, it's because he's an alcoholic and he's having withdrawals. So this is like another Monash. I'm pretty certain after last year they just scrapped all these questions and made new ones. But if you get it, like it's just good to know. So yeah. Okay, last 2. 53-year-old woman, loose bowel actions, last 3 months, been regular. Mother died at age 75. There you go.
Yeah.
So, bit of family history. There's multiple options, kind of. Want to have a crack? I think so too. Yeah, perfect. And the last one. Oh, did you say J?
Oh, it's not cancer.
No. So J is more of a precursor. Like technically, villus versus adenomatous villus is more likely to become cancer, but again, it's a precursor, so it's not the technically right answer. Okay, last one. Let's go in a bag. Go out in a bag. One of us, 24-year-old uni student, has been suffering from constipation. Ointment which led to improvement but caused headache. So before you guys get the diagnosis, what's the ointment?
Yeah.
Perfect. So what could the condition be? Burning pain or defecation. I'm not sure if you're joking or not. E is like you know how you have what's the one for the eye? Amaurosis fugax. Yeah, like, I think proctalgia fugax is like
Yeah.
Then it's like
burning pain, bright blood. Most likely the pain is because of the blood. What could it be? Okay, hearing fishes. Anyone else?
external.
Hearing external hemorrhoids. Is it? Okay, I'm hearing external hemorrhoids, so we have 2. Anyone else? Proctalgia fugax. Okay, 3.
Cancer.
You just want everyone to die, don't you? All right. In the interest of time, I'll just go. So in this case, it's a fissure. Reason it's not external hemorrhoids is because she's not going to be prescribed an ointment for hemorrhoids. Like it's just sort of reasoning it that way. Like the symptoms are pretty similar, but you won't get GTM for hemorrhoids. Proctalgia fugax won't present with this presentation. Right. All right. Thanks for coming along, guys.
Thank you.